Hello and welcome to my channel. Today I'm going to talk about upper limb anatomy related to the MRCS. So I have made these MCQs which are the quick guide for a quick revision. But the main importance of these MCQs is that I have added relevant diagrams to guide you and help you with the visual memorization. Okay, so let's get started. So our first statement says that there is a 70-year-old man who had fallen and he sustained a fracture of scaphoid. There was a plan to insert a screw. Now, what the question is asking is that which structure lies directly medial to scaphoid. Okay, so the MRCS anatomy section is very important. They are going to ask you a lot of relationships, which structure is medial, which structure is lateral, which structure is anterior, which structure is posterior. So I would like to advise you to take notes, focus on the diagrams, especially from the netter, and use a relevant book to have a complete package of knowledge. Because doing only these MCQs and reading their explanations are going to be deficient. That is why I have added these diagrams so that they will be your platform to build some basic knowledge. So let us go into the detail of this diagram. So first of all, we have to define that which side is lateral and which side is medial. So this radial side is going to be the lateral side and this ulnar side is going to be the medial side. So which structure is medial to scaphoid? So this is going to be lunate. This is one point. The second point is that they can also ask you that they give you a reference of lunate and they can ask you what is lateral to lunate. Then your answer will be scaphoid. And what is medial to lunate? You will be answering triquetral. And then number fourth over here will be the pisiform. Now this is the proximal row. Now talking about the distal row from lateral to medial, we will have trapezium, trapezoid, capitate and hamate. These are the metacarpals in orange and we have phalanges in green. So the next statement says that there is an 18-year-old lady who had trouble with hyperhidrosis, that is excessive sweating of the hands and arms. Sympathectomy is planned. So they're going to ask you some relationship question or they're going to ask you a specific question. Both could be the options. Which should the surgeon divide to most effectively treat her condition? So in this case, we have to see that hyperhidrosis is going to be caused by sympathetic overload. So sympathetic ganglion specifically at T2 and T3 are going to be cut. So as you could see in this diagram, this sympathetic chain in the form of sympathetic ganglions are present on both sides of the vertebrae. So we have to see that the surgeon will be cutting from this point to this point of T2 at T3 to treat this patient. So next statement says that which is a branch from the third part of the axillary artery. So that is going to be the posterior circumflex humeral. Other branches include subscapular and anterior circumflex. So as I have explained this in the arterial section, I will explain this again as well. So axillary artery begins at the lateral border of the first rib and extends till the lower border of peris major. Pectoralis minor divides this into three parts. The first part gives superior thoracic artery. Second part gives thoracoacromial and lateral thoracic artery. The third part gives posterior and anterior circumflex humeral and subscapular artery. So next question here states that there is a 53-year-old lady who presents with pain and discomfort in her hand. She works as a typist and pain is worse when working, also suffers at night. However, little finger is less affected by the pain. Which nerve is most likely to be affected? In this case, median nerve is going to be affected. So the diagnosis over here is going to be carpal tunnel syndrome, but let me explain a few anatomical points related to the median nerve. So median nerve arises from the medial and lateral cords of the brachial plexus. In the arm, it is related to the brachial artery. So with the brachial artery, it initially lies laterally, then comes anteriorly, and then lies at the medial side of the brachial artery. Now, median nerve at the elbow passes through the cubital fossa, and it also passes between the two heads of pronator teres. This is a very important relevant point specifically to MCQs. Then median nerve in the forearm is going to supply all the muscles except flexor carpi ulnaris and the medial half of the flexor digitorum profundus. Then in the hand, it is going to only supply four muscles. That includes the lateral two lumbricals, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. So the mnemonic for this is LOAV. Now again, there is some sensory supply for this that includes the lateral aspect of the anterior palm and lateral 3.5 fingers on the anterior aspect. So next statement is 32-year-old man had tingling in his hand, radial deviation of the wrist, mild plowing of the fingers with fourth and fifth digit being relatively spared. So radial deviation means that there is some pathology with the ulnar side. Ulnar side wrist stabilizer is the flexor carpi ulnaris. But in this case, as ulnar nerve is supplying the flexor carpi ulnaris and it is not working properly, so there is going to be a radial shift of the wrist. So the answer would be ulnar nerve damage at the elbow joint. So let's talk about the anatomy of the ulnar nerve. Ulnar nerve begins from the medial cord of the brachial plexus. It runs in the arm and then it passes behind the medial epicondyle. On entering the forearm, it passes between the two heads of the flexor carpi ulnaris, and in the forearm, it supplies only two muscles, that is the flexor carpi ulnaris and the medial half or the ulnar half of the flexor digitorum profundus. Then it runs down to the hand where it passes superficially to the flexor retinaculum into the hand. First of all, it supplies the hypothenar muscles, which are the muscles going to the little finger, which includes opponens digiti minimi, flexor digiti minimi, and abductor digiti minimi. And then palmaris brevis, which is one of the very small muscle of the hypothenar. Then it supplies all the dorsal and palmar interossei. It supplies the medial two or the ulnar two lumbricals. Then in the thenar eminence, it is going to supply one very important muscle, that is the adductor pollicis. So 20-year-old man had a stab injury in the thenar eminence over here, and there is a 2 centimeter laceration with loss of sensation in the thumb and index finger. The patient is having loss of sensations from the thumb and index finger, and also there is weakness of thenar muscles. So we can think that there is some damage to a structure whose sensory and motor supply is being compromised. So in this, the answer would be sensory and motor branches of the median nerve. So orange color over here is by the palmar cutaneous branch of the median nerve, and the purple color is showing you distribution of the median nerve by the common and the proper digital branch. So here one point that needs to be understood is that the recurrent branch of the median nerve is only the motor branch, which is supplying the muscles of thenar eminence. So that cannot be damaged because there is also some sensory loss. So that point must be kept in mind. So 40-year-old lady trips and falls with severe laceration to the left arm, has lost the ability to adduct the fingers of the left hand, injury to which nerve is most likely to occur. So that is the ulnar nerve. As we know that all the interossei, the dorsal as well as the palmar, are supplied by the ulnar nerve. So next question is, which structure separates the cephalic vein and brachial artery in the cubital fossa? So this is a very peculiar type of question because this is not asking about medial and lateral. It is asking about above and below. So first of all, the most superficial structure in the cubital fossa is cephalic vein. and the deeper structure is the brachial artery, and what is present in between them is the bicipital aponeurosis. So you're going to encounter such type of questions, so it is better to focus on the diagrams, especially from the netter, and have a good grasp of the concept that what structure is present medial, what structure is present lateral, which structure is present from above and below in which sequence. So that is the core basis of passing the MRCS anatomy section. So which structure passes through the quadrangular space near the humeral head? So the answer would be axillary there. But let me explain the boundaries as well. Quadrangular space is bounded superiorly by teres minor, inferiorly by teres major, medially by the long head of the triceps, and laterally by the surgical neck of the humerus. Axillary nerve and posterior circumflex humeral artery are the contents of the quadrangular space. From the triangular space, we have superior boundary of teres minor, inferiorly we have teres major, and laterally we have the long head of triceps. From triangular space passes the circumflex scapular artery. Triangular interval. Triangular interval is bounded superiorly by teres major, medially by the long head of triceps, and laterally by the shaft or lateral head of the tricep. From this passes radial nerve and profunda brachii artery, which is the deep branch of the brachial artery. 56-year-old man who is on long-term TPN and had a PICC line, which is peripherally inserted central cannula for long-term venous access, and the person states that it is inserted in the basilic vein at the elbow, where it is inserted over here. So into which venous structure is going to be the tip of the catheter? So I have explained this point in the venous section of the upper limb anatomy. You can go there and understand that in detail as well. So what happens over here is the basilic vein, it's the medial vein. It pierces the deep fascia at the lower border of teres major, and then it is combined by the vena comitatus of the brachial vein, which is one of the deep veins. And they both combine, the basilic vein and the brachial vein, to form the axillary vein. However, if a cannula is inserted over here, it is directly going to enter the axillary vein. So I hope you're starting to have an idea that what sort of questions you're going to encounter. You're going to have a deep understanding of the concepts of the anatomy so that you can encounter any question. So you can take some time and go through this detail. So thank you very much for listening.